Good morning. The 20th Lourdes Manahan Lecture Rheumatology is now streaming live from the University of the Philippines, Manila. I am Dr. Heizel Reyes of the Division of Rheumatology here at UPPGH, your moderator for this session. And yes, it's 11 o'clock in the morning when we're 1 hour earlier than usual. We would like to thank our sponsor, AstraZen Med or AZ Med, and all of our participants, all 1,000 of you, for joining us today. As usual, we would like you to ask your questions by posting them in our Q&A box at the bottom of your Zoom screen. We will address them all during the open forum. You will receive your certificate of attendance a week after you submit your evaluation form and post test. So there's no need for you to sign up for your attendance. We will take note of them as you submit your evaluation form and post test. The link for these will be posted later. So this is the 4th year that we're doing the LMLR online. And today will be the first of our webinar series for this year. The LMLR aims to teach healthcare professionals with the basics and also provide updates in rheumatology as an advocacy initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. For this year, our theme is Life to the Max. We wish to emphasize a holistic understanding of our patients and their diseases and ways through which we can make our patients' lives better. LMLR is in support of your Sustainable Development Goals number 3 for good health and well-being, and SDG 4 for quality education of the World Health Organization. And because you might miss us in between webinars, the Division of Rheumatology is happy to announce that its publication, The Atlas of Rheumatic Diseases in the Philippines, is now available for those who wish to purchase. So you may actually scan the QR code here, reach to us by email or through telephone or Viber or whatever you're using, and tell us if you want to purchase a copy. So going back to this lecture, we will be focusing on SLE, how we are able to diagnose and monitor the disease. Can we move that slide? And strategies on disclosing important and not so good news to our patients. We're deeply honored to have 2 well-respected speakers today. The first one is our graduate of our Rheumatology Fellowship Program at the Philippine General Hospital. We're happy that she's now the head of the Section of Rheumatology at the Department of Medicine in the University of the East Ramon Magsaysay Medical Center. She's also an active consultant at the East Avenue Medical Center, where she is the Research Fellowship Coordinator, and also the Philippine Heart Center and the General Miguel Malvar Hospital. Ladies and gentlemen, let's give a welcome to Dr. Therese Eileen Lladoc-Natividad. Our second esteemed speaker is Dr. Victoria Patricia de Llana. She completed her general psychiatry residency and consultation psychiatry fellowship at the Philippine General Hospital. Nabubulol na ako sa haba. So Dr. de Llana is an active psychiatry consultant at the Medical City, the Quezon City General Hospital and Medical Center, the ACE Medical Center, Quezon City. She's also the care team lead of the Board of Directors of Mind Care Club and is part of the core team of the Medical City Center for Gender Health and Wellness. But most of all, she is part of our community here in PGH as a clinical associate professor in the Department of Psychiatry, UP College of Medicine. So tama po yung napapanood nyo. We are in the LMLR. This is not an extension of Miss Universe. So ladies and gentlemen, let us welcome, first of all, our first speaker, Dr. Natividad, to share their expertise with today's lecture.
Good morning to everyone. Thank you to the UPPGH Division of Rheumatology for inviting me as speaker to the LMLR lecture series. This morning, I have been tasked to help us recognize the presenting manifestations of SLE and lupus flare, and to discuss the implications of uncontrolled lupus disease activity. This illustration is known to most, if not all of us. SLE is the prototypical autoimmune rheumatologic disease in which cells and organs undergo damage over a span of time. In a genetically susceptible individual, an abnormal immune response results in the deposition of autoantibodies in immune complexes, causing inflammation and eventually tissue destruction. This multi-system disease is diagnosed on clinical grounds in the presence of characteristic autoantibodies, which are usually present years before clinical disease develops. Although it can occur in men, the typical patient is a female in the reproductive age with a female-to-male ratio of 9:1. The disease is often relapsing and remitting and may follow an unpredictable pattern. Majority of patients, however, have continuous active disease requiring anti-inflammatory treatment, interspersed with disease flares demanding additional immunosuppressive therapy. Early mortality is due to active disease, infection, and thrombosis. Late mortality, on the other hand, is from late complications of disease, atherosclerotic heart disease, or infections. At disease onset, only one or a few organ systems may be affected, with the appearance of additional manifestations over time. This table from UpToDate shows the frequency of signs and symptoms at onset and at any time. Note that the most frequent manifestations at onset are skin findings, arthritis or arthralgia, fatigue, and renal abnormalities. Similar findings were noted in a study in 2008 by Drs. Villamin and Navarra, where 1,070 patients fulfilling the ACR criteria of SLE were included. The following were the most common clinical manifestations on diagnosis: arthritis, malar rash, renal involvement, photosensitivity, and oral ulcers. In 2018, Drs. Ange Magbitang-Santiago and Drs. Mike and Sherika T. looked at the clinical manifestations of 255 Filipino patients in their cohort who fulfilled the SLIC criteria for SLE. Mucocutaneous involvement, arthritis, and renal disorder were the most frequent manifestations as well. This table from Harrison's summarizes the clinical manifestations of lupus throughout the duration of the disease, the most prevalent of which are systemic, musculoskeletal, cutaneous, hematologic, followed by neurologic and cardiopulmonary, renal, GI, thrombosis, and ocular. For the health practitioner, the challenge lies in recognizing the constellation of clinical features by which lupus may present and tying them up together with the appropriate test to suspect the diagnosis. This can be more straightforward in cases where there is already multi-system involvement upon presentation, and can be more challenging when isolated complaints bring the patient to the clinic. As Dr. Pensurga once said, in a young female presenting with multi-system disease, SLE should always be a consideration. Though mainly used for inclusion of patients in research studies, the different classification criteria for SLE may guide clinicians in their diagnosis of lupus. The 1997 ACR criteria require that the patient satisfy at least 4 of 11 criteria. It has a sensitivity of 83% and a specificity of 96%. Note that the highly correlated cutaneous features of malar rash and photosensitivity were duplicated, and it missed other cutaneous manifestations which are included in the SLIC. It also did not include many neurologic manifestations of SLE. Other immunologic information such as low serum complement was not included as well. This was included in the SLIC. The SLIC criteria, on the other hand, require either that the patient satisfy at least 4 of 17 criteria, including at least 1 of the 11 clinical criteria and 1 of the 6 immunologic criteria, or that the patient has biopsy-proven nephritis compatible with SLE in the presence of ANA or anti-dsDNA. It has a higher sensitivity of 97%, but a lower specificity of 84% compared to the ACR. The most recent classification criteria are the 2019 EULAR ACR that require an entry criterion of a positive ANA at 1 to 80 dilution. These were developed to improve detection of early onset SLE, as well as to improve the sensitivity and specificity of previous criteria. Additive criteria consists of 7 clinical and 3 immunologic categories, each of which are weighted from 2 to 10. Patients are classified as having SLE with a score of 10 or more points. We now proceed to defining what a disease flare is. In 2006, the Lupus Foundation of America sponsored an international effort to develop a clinically meaningful definition of flare, and this is what they came up with. A flare is a measurable increase in disease activity in one or more organ systems involving new or worse clinical signs and symptoms and/or laboratory measurements. It must be considered clinically significant by the assessor, and usually there would be at least a consideration of a change or increase in treatment. Central to the measurement of increases in disease activity are the disease activity indices that strive to capture the different manifestations of SLE. These are the Systemic Lupus Erythematosus Disease Activity Index, or your SLEDAI, the British Isles Lupus Assessment Group, or BILAG Index, the Systemic Lupus Activity Measure, or your SLAM, and the SLAM-R modification. And last, you have the European Consensus Lupus Activity Measure, or your ECLAM. In contrast to the original SLEDAI and Selena SLEDAI, which measure activities for the past 10 days, the SLEDAI 2000, which we will focus on this morning, score manifestations for the last 30 days based on 24 items with weighted scores across organ systems. Preferential weighing is based on the manifestations of CNS involvement and vasculitis. A total score can fall between 0 and 105, with a higher score representing a more significant degree of disease activity. In clinical practice, the patient's history, PE, and lab results primarily guide the assessment of disease activity. The following may herald an increase in lupus disease activity: anemia, leukopenia, thrombocytopenia, low complement, elevated ESR, a rise in anti-dsDNA antibody levels, or any combination of these. Proteinuria, hematuria, urinary casts, and a rise in creatinine levels may signify renal involvement in SLE. As such, the following tests are to be monitored during clinic visits: your CBC, urinalysis, ESR, serum C3, and anti-dsDNA. When assessing our patients, it is important to distinguish between features attributable to active SLE or disease flare and those that can be ascribed to chronic damage, drug toxicities, and other conditions such as infection. Another important aspect of patient monitoring is the assessment of SLE effects distinct from disease activity. Damage indices measure the accumulated and irreversible damage that has occurred since disease onset because of lupus activity, medications, and comorbid conditions. The pattern of damage is said to increase in a steady linear fashion over time due to the consequences of persistent inflammation. And about 50% of all patients with SLE will have some form of organ damage 10 years after their diagnosis. Factors associated with damage are older age, disease duration, male gender, non-Caucasian ethnicity, disease activity, corticosteroid use, poverty, hypertension, and abnormal illness behaviors. Damage predicts further damage, and its early onset is associated with poor prognosis, decreased quality of life, and increased mortality. Antimalarials, however, are protective against it. The SLIC ACR Damage Index measures damage occurring since the onset of lupus in 12 organ systems with a maximum score of 47 points. These are your ocular, neuropsychiatric, renal, pulmonary, cardiovascular, peripheral vascular, gastrointestinal, musculoskeletal, skin, gonadal, endocrine, and malignancy. Findings should have been present for at least 6 months. early accumulation of damage is associated with a poor prognosis and increased mortality. After discussing disease and flare manifestations as well as damage accrual, we now go to stating the goals of treatment in SLE. These are to achieve remission or low disease activity, to prevent organ damage, to minimize drug toxicity, and to improve quality of life. Remission is defined as the absence of clinical disease activity as measured by a SLEDAI 2000 score of 0 and a physician global assessment score of less than 0.5. The patient may be on antimalarials, low-dose glucocorticoids, and/or maintenance doses of immunosuppressive therapies. Sustained remission is the ultimate goal of SLE management, but this is rare. On the other hand, the lupus low disease activity state, or your LLDAS, accepts a SLEDAI score of equal to or less than 4 with no activity from major organ systems. So when we say major organ systems, we mean your renal, CNS, cardiopulmonary systems, vasculitis, gastrointestinal manifestations, hemolytic anemia, or fever. There should also be no new clinical activity compared with the previous assessment, a PGA score of 1 or less than 1, a prednisone dose of equal to or less than 7.5 milligrams per day, and the patient has to be on maintenance doses of antimalarials and immunosuppressive therapies. The various definitions of low disease activity states are associated with comparable rates of remission in terms of halting damage accrual and prevention of flares, making the LLDAS an alternative and more achievable, yet not ideal, treatment target. In the next 2 slides, I will be sharing some studies on the advantages of achieving LLDAS or remission. The first one is a prospective multinational longitudinal study by Ratnayake et al., who used data from 3,811 SLE patients from the Asia-Pacific Collaboration Cohort to look at LLDAS and remission and the risk of mortality. In this cohort, 80 died during the observation. They then compared the percent of patients who achieve LLDAS and remission at least once and at least 50% of observed time, which we will call your LLDAS 50 or your remission 50. So they compared among those who died and those who remained alive. They found that LLDAS 50 and remission 50 were associated with reduced risk of mortality. They concluded that LLDAS significantly reduced the risk of mortality in SLE patients, and that remission did not further reduce the risk of mortality compared with LLDAS unless the lower glucocorticoid thresholds were used. Golder et al. Look at LLDAS and health-related quality of life among 1,422 patients with SLE. They found that patients in LLDAS had better physical and mental component scores and significantly better scores in multiple individual SF36 domains. The third study by Piga et al. Looked at failure to achieve LLDAS 6 months after diagnosis and early damage accrual. They concluded that the presence of any organ damage at 18 months was significantly associated with lack of LLDAS at 6 months. They also found that disease manifestations with the lowest remission rate during follow-up were increased anti-dsDNA, low serum complement, and renal abnormalities. The presence of renal involvement and treatment initiation was significantly associated with failure to achieve LLDAS both at 6 and 18 months. Another study looked at remission and LLDAS and damage accrual, concluding that the presence of prolonged remission and LLDAS 50 were associated with reduced risk of damage accrual. From these, we see that achievement of remission or LLDAS were associated with favorable outcomes in regard to mortality, damage accrual, and quality of life. Can we then anticipate which patients can achieve these treatment targets? So 2019 study examined the predictors of predominant LLDAS among 2,228 lupus patients. In this group, only 52.5% achieved LLDAS 50. The following were identified as negative predictors of LLDAS: African American ethnicity, the presence of serositis, renal activity, arthritis, malar and discoid rash, having hypocomplementemia and thrombocytopenia, and having positive anti-RMT and anti-dsDNA. On the other hand, the positive predictors of LL-DAS were older age at diagnosis, longer disease duration, higher education, and greater percentage of time taking hydroxychloroquine. Indeed, uncontrolled disease activity or failure to achieve either disease remission or LL-DAS translates to higher mortality, higher risk of organ damage, more frequent disease flares, and poorer health-related quality of life. Herein lies the importance of prompt disease recognition and timely treatment initiation. Treatment of lupus depends on the patient's clinical manifestations and severity of disease. The EULAR differentiated between mild, moderate, and severe disease activity in this manner. But before we go there, let me just discuss or orient us to the BILAG index. So for BILAG index, A would pertain to your severe disease requiring increases in prednisone to more than 20 milligrams or the addition of immunosuppressive agents. Your BILAG B is less active disease requiring low-dose prednisone or symptomatic treatment with NSAIDs and or antimalarials. And BILAG C would be mild disease requiring symptomatic therapy such as simple analgesics or stable disease on current therapy. So for that, we start with the mild disease activity, and these are also usually patients presenting with constitutional symptoms, mild arthritis, rash that is less than or equal to 9% of the body surface area, platelets of 50 to 100, those with a SLEDAI score of equal to or less than 6, and a BILAG C or 1 or less BILAG B manifestations. On the other hand, you have your moderate disease activity, those patients presenting with RA-like arthritis. Their rash covers a larger surface area of 9 to 18%. Some of them may present with cutaneous vasculitis of 18% or less of the body surface area, those with platelets 20 to 50, and those presenting with serositis. These patients may have a SLEDAI score of 7 to 12 and 2 or more BILAG B manifestations. Lastly, we have those with severe disease, those presenting with major organ-threatening disease of nephritis, cerebritis, myelitis, pneumonitis, and mesenteric vasculitis, platelets of less than 20, TTP-like disease or acute hemophagocytic syndrome, a SLEDAI of more than 12, and those with 1 or more BILAG A manifestations. So this diagram presents the treatment of non-renal SLE with remission and low disease activity as treatment targets. General principles in management that applies to all patients include photoprotection, immunization, diet and nutrition, exercise, smoking cessation, and control of BP, lipids, and sugars. Antiplatelets may be given to SLE patients with high-risk APL profile. The choice of drug therapy is highly individualized and depends on the predominant symptoms, so whether a patient is presenting with mild, moderate, or severe symptoms. It also depends on the organ involvement and the disease severity. Note that all patients with SLE with any degree and type of disease activity are to be given hydroxychloroquine unless contraindicated. Intake of hydroxychloroquine is associated with a positive impact on patient survival. It is seen to reduce flare rates. It reduces SLE disease activity of all types by 50%. It reduces constitutional symptoms, musculoskeletal manifestations, and mucocutaneous manifestations. It can potentially reduce thrombotic events, damage accrual, and cancer. Some patients with mild disease may require no additional therapy apart from hydroxychloroquine, while others may require short-term use of NSAIDs or low-dose steroids. Immunosuppressives like methotrexate or azathioprine may be added if refractory. Patients with moderate disease activity are those having significant but non-organ threatening disease and usually respond to hydroxychloroquine plus short-term therapy with 5 to 15 milligrams of prednisone daily. A glucocorticoid-sparing immunosuppressive agent is often required to control symptoms. Patients with severe or organ-threatening manifestations, which includes renal or CNS involvement, generally require an initial period of intensive immunosuppressive therapy to control the disease and halt tissue injury, usually with high doses of systemic glucocorticoids. A longer period of less intensive and ideally less toxic maintenance therapy follows to consolidate the remission and to prevent flares. Additional immunosuppressive agents are typically added as glucocorticoid-sparing therapy and may include your mycophenolate mofetil, cyclophosphamide, and rituximab. So in summary, SLE is a multi-system disease diagnosed on clinical grounds in the presence of characteristic autoantibodies. In assessing patients with SLE, one must distinguish between active SLE, chronic damage, drug toxicity, infection, and others. The goals of treatment are to achieve remission or low disease activity, to prevent organ damage, to minimize drug toxicity, and to improve quality of life. Lupus low disease activity, or LLDAS, is an achievable target in lupus management, sorry for the typo, that is associated with better health-related quality of life, reduced risk of damage accrual, and reduced risk of mortality. Treatment depends on the clinical manifestations and severity of disease. Now, for example, you have a patient in front of you and you have diagnosed her as a case of SLE. How do we best disclose the diagnosis to her, knowing that this would be life-changing? For this, I will pass you on to our next speaker. Thank you very much for your kind attention.
Ako po si Lladoc-Natividad, 64 years old po. Una po malaman po na may lupus ako, medyo masama po ang pakiramdam ko, medyo umiyak din po ako, pero wala rin po ako magagawa.
Nalaman ko po nung may lupus ako, nalungkot ako kasi ang dami ng bawal.
Ang kinagod nyo is hindi naman siya nakakahawa. Nga lang marami din mga bawal na hindi tatanggol na katulad yung pagbibilag sa araw.
Na-diagnose po ang lupus noong year 2019. Hindi po naging sa akin yung resulta kasi parang hindi nagtanggapin. Pero wala ko na po natanggap ko na rin at unti-unti ko na umaayos yung kanila.
Parang hindi ko namin alam kung anong sakit na yun. Dahil ginawa ko ng mga kapatid ko ay tinignan nila sa internet ko ang experience mo. Ay parang hindi mo panihala kasi yung lang sa dahil namin. Pero hanggang sa ngayon po, tanggap naman ako.
Ako po si Therese Santos, isa pong lupus patient. Ako po ay na-diagnose noong 2013 na meron po akong naranasan na pananakit ng mga joints, butterfly rash, at mga rashes sa buong katawan, pati po mga lagnat at iba't ibang infection sa katawan. Nung una ko pong nalaman na may mga sakit po akong ganun, hindi pa po ako agad na-diagnose. Iba't ibang hospital po ako pinuntahan. At pagkatapos po nung nalaman ko na may lupus ako, sabi po ni Doc na kailangan po mag-ingat po ako sa araw at saka sa stress kasi bawal po yun sa may lupus. So, sa totoo lang po, nalungkot po ako, pumayat po ako ng todo, tapos hindi na po nakakapasok sa trabaho. Then, sa ngayon po, lumalaban pa rin po, patuloy pa rin po sa inom ng mga gamot at pagsunod sa mga doktor. Salamat po.
Good morning. Thank you so much to the Division of Rheumatology for having me. So this morning we're going to be talking about disclosing the diagnosis of lupus. So I think all of us here are no strangers to disclosing bad news to our patients. So I hope to be able to validate a lot of the good work you're all doing for your lupus patients and also to give you something to think about, something new to think about, and another way of seeing patient disclosure. Okay, so let's start from the basics. What is bad news? it is any information which adversely and seriously affects an individual's view of his or her future. Breaking it to the patient is a frequent and stressful task. So why is it important to disclose bad news to our patients? Number one, our patients want the truth. And of course, those are their symptoms and their bodies. So for some patients, it is a relief to finally have a name, a label, what to call everything they've been feeling. Okay, so for some, it can actually give them comfort. Number two, we have ethical and legal imperatives to, of course, letting them know and being there for them and helping them make clinical decisions, because a lot of the decisions on management we can propose, but we generally don't do it alone and decide with our patients. Okay, and next, of course, with them knowing their condition, the possible outcomes, etc., if they undergo this treatment or that, we're able to get better clinical outcomes, or at least have them have realistic clinical outcomes. Okay, and then going back to the second point, it will also help us decrease our risk of having legal problems later with our patients if they're the litigious type, para hindi tayo makasuhan ng malpractice, basically. Okay, so nobody wants to be the bearer of bad news. But the thing is, in our profession, well, sometimes bad news is really part of it. So for us, the bearers of bad news, we feel this anxiety, a burden of responsibility for the news, even if we know it's not really our fault that they've got lupus, we didn't cause it. Of course, none of us really want to deliver the bad news. And we also fear negative evaluation. So for some of us, we were hoping for a different diagnosis, or at least lupus was not our first differential, but when all else is ruled out except the lupus, then that's it. So sometimes, well, we feel that it's kind of scary to be the one to disclose that to the patient, especially if it looks like you quote unquote made a mistake. So there are also some patients and families who tend to devalue their doctors once bad news is given. Hindi ka raw marunong, or you're a bad doctor because that's your diagnosis. So sometimes that happens. I already mentioned the reluctance to deliver bad news, and also it's very important and stressful for us to be able to walk that fine line between honesty with the patient and not destroying their hope, especially for a chronic condition that is characterized by exacerbations and remissions. And of course, dealing with the patient's emotions. I think that's one of the most scary parts of disclosing bad news to patients. Okay. So what are the goals for breaking bad news? Number one, we should be able to gather information from the patient, because that's going to tell us how we're going to proceed with our management. To provide information they can understand in accordance to what they need and want in terms of their everyday life, and in terms of their treatment, in terms of how to face this. Next, breaking the bad news enables us to support the patient. So we're able to employ skills that will break it to them gently. And of course, to be able to fight against that isolation they will feel after being given that diagnosis, especially since we all know that there are so many people who are diagnosed with lupus and are living with it, and actually are living great lives with it. Okay, so lastly, the last goal for breaking bad news is to develop a strategy in the form of a treatment plan with the input and cooperation of the patient. So I will be going into a little more detail with all of this later. So One of the simplest ways for me to be able to disclose the patient's diagnosis to them is actually the SPIKES protocol. So it's a 6-step strategy for breaking bad news. So what are the 6 steps? SPIKES. Okay. This protocol helps encourage the patients to participate in treatment decisions. And since it's already step by step, it increases our own confidence in delivering the bad news. And once we're more confident, we get less stressed out and less burned out. Okay. So in real life, we don't necessarily have to go through all 6 steps, but if you'd like to do so, or if the 6 steps are required, we need it in this order. Okay, so again, SPIKES protocol, SPIKES. Okay, so step 1, S, setting up. It's very important that you're able to get into the right physical space and the right headspace for said interview. So how does that work? You set up the interview in terms of scheduling with the patient, and you can have a mental rehearsal with yourself as to how you're going to go about it. Instead of just walking in and just blurting it out, you've got a spiel. So for a lot of us who have hit fellowship, senior fellowship in our respective subspecialties, we've already kind of gotten a spiel, right? So this is the time to go over it again. If there's anything that you'd like to improve or anything you miss in your usual spiel, now's the time to fix it and rehearse it in your head. All right? Privacy is important, especially when you're going to deliver bad news. Involve significant others, so family, friends, sometimes the barangay captain kung sila pala nagdala sa pasyente. That happens sometimes in PGH, but it's always, always, always important to ask the patient who they would like to have in the room with them. Okay? Then it's very important to sit down. Why sit down? Because it signals to the patient that the two of you will talk. You're making time for this. Okay? Then it allows you to also connect more with the patient. And also manage time and interruptions. If you're on call, maybe you can carve out 30 minutes, roughly 30 minutes, or okay, fine, 15, 20, 30 minutes, just to do this disclosure. So if you're holding your work phone, your duty phone, maybe you can ask someone to cover for you first, just so you can get this done so that your time and interruptions are managed and minimized. Okay, so that's S, setting up. P, perception. So we have to start out with asking for the patient's perception of the condition. So always, always, before you tell, ask. So what I do very often is, ask, so far, what do you recall, or what have you been told, or what do you understand about your symptoms? This allows us to meet the patient where they are. And so you're able to see how the patient perceives the medical condition, everything that's happening. And also, if you start with that, you're better able to correct misinformation and to tailor the news to the patient's understanding. And it also lets you get a feel for the language that the patient needs for you to understand. Okay, and also it determines if the patient is in denial. So generally, in psychiatry, if we're dealing with denial, we don't always actually deal with it head on, especially if the patient is still adherent to the treatment regimen, still participates in care, still cooperative. It's okay. The only time we tend to deal with it is if it's starting to disrupt care. Okay, so if the patient is in denial, just keep it in mind and see kung kailan kailangan patulan and when we can just leave well enough alone because the patient is still able to take steps towards recovery. Okay? So S, setting up the interview. P, getting the perception. Now we go to I, invitation. So obtain the patient's invitation for disclosure of full information. So again, it will give you cues on, where the patient is, because you have to meet them there. And it can also help you plan for the following discussions with the patient. So in terms of lupus, besides taking your history of symptoms, taking your physical exam, right? You also do your labs. So sometimes, just when we're ordering labs, just when we're disclosing that we're going to test for lupus, and these are the tests we need, pwedeng dun pa lang, you can go, how would you like me to give the information about the test results? Okay? So there are some patients, sabi mo na, doc, give it to me straight, doc. There are also those who don't want to know. They just want to know what you recommend, and then they'll just go for it. There are some who are like that. That's also okay. Again, if they're not disrupting the care, it's okay to leave well enough alone. Okay, so however, if they, don't want to know the details, just offer to answer any questions they may have in the future, because they can change their mind, basically. All right, so S, setting up. P, perception. I, invitation. K, knowledge. So it's very important to give knowledge and information to the patient. And again, I can never emphasize this enough. Meet the patient where they are. Start at their level of understanding. Use non-technical words. So I'll go back to the previous tip again. Listen to what language they use, because that is the level of language you will use. If you start using the big words, they won't necessarily remember it, and it might frighten them more. So at this point, you might want to recheck your spiel, your mental rehearsal, because you might be accidentally using technical words that we take for granted that we all know the meaning of. So it's okay to disclose, to speak with the patients in Taglish, but the tag part or the lish part, they all have to be terms that the patient can understand. Okay? Avoid excessive bluntness. Okay? But that's pretty much a thin line. Also avoid sugarcoating too much. So again, that kind of gets better with practice. So yeah. And then give information in small chunks, then pause, just to make sure that they haven't quite gotten lost. And then if the prognosis is not so good, with lupus, it's not that way all the time. So avoid saying there is nothing more we can do for you. This part, I just added it, but it's a little more for the terminally ill patients. One of the greatest fears of our patients, whatever their diagnosis is, even if it's something we can live with, is being abandoned. So whatever the prognosis is, it's very important that they know that we will not leave them, and because there really is something we can do all the time. If the patient is terminally ill, then we're still able to keep them comfortable, maintain their dignity, and give as much functionality as we can. Okay, so yeah, going back to the lupus diagnosis, it's also very, very important for this knowledge part to make it real for the patient. What is the everyday like? What is possible? What changes they can expect in their daily lives, so that they're able to prepare for it. Okay. What I've noticed is patients feel a bit more hopeful when they are told anecdotes about other patients who are living with the same, so that they know they're not alone. And another is that if you use those little anecdotes to teach them coping skills, how to survive, the tricks your other patients have learned or you've learned from your patients, so that they'll also be able to live with and live around the lupus flares. That's one. Another one is also to give the patients a little room for kind of processing after they're told that the diagnosis is lupus. Because all of us, going back again to the mental rehearsal, to our spiels, again, delivering bad news is not fun. So we tend to just recite our spiel and then we're done and, duty discharged. Great, thanks, patient. But actually, what is more realistic is, as soon as they hear lupus and that they've got it, some of them kind of hang. So they're going to miss your spiel. Okay? So give information again in small chunks and check their understanding. Pause often. You might have to repeat later. Okay? Okay. So S, setting up the interview. P, perception. I, invitation. K, knowledge. E, emotions and empathy. So again, give them time. Okay? So an example of an empathetic response. I'm sorry, the news is, well, not as good as we hoped. That kind of thing. So observe for emotion. What I find most useful is to watch the eyes. You can see, diba, if tears are starting to form. So I would advise, part of setting up the interview pala is to bring tissue and not toilet paper. And for those of us who are disclosing to inpatients, when you come in, just check which table the tissue is on because you might need it. Okay. For some, it's useful to actually have the little plastic packs of interfolded tissue in their coat pocket already, just to be prepared. Okay, so observe for emotion, identify the emotion. You seem to be looking anxious. You seem to be looking sad. Am I interpreting this correctly? That kind of thing. And then if they give the affirmative, then it's an option to explore further. What are you thinking now that makes you feel that way? Okay? Because again, it's really important to meet the patient where they are so that you have cues on where to go from there. Okay. So give the patient time to express those feelings. And if the patient starts crying, again with the tissue, don't panic. It's okay if they cry. Just sit there and be silent and give tissue. I find tissue very, very useful because even without saying anything, it's a silent way of being able to say that, I see you, I empathize with you. It reduces the patient's isolation, expresses solidarity, and validates the patient's feelings or thoughts as normal and to be expected. All right, so again, S, setting up the interview. P, perception. I, invitation. K, knowledge. E, emotions. And S, strategy and summary. So having a clear plan for the future makes both of you less anxious and uncertain. What is really, really important is to align the goals. So if they show a lot of emotion, if you're noticing that they're already hanging, their brains are on beta, ask them if they're ready to discuss options already. And be very supportive. If you need me to come back a little later, if you need me to come back tomorrow, that's okay also. Because there's a chance nga na they won't be able to decide anyway. They're still reeling from the news. So you have to give them that. Then, if they say they're ready, I'd like to think most of them are. Okay, we present treatment options. We share the decisions, and we always go back and check if there's any misunderstanding. So what are the frequently asked questions on patient disclosure? Well, number one, a lot of those who have been practicing for quite some time, you'll start to notice a pattern on what the patients and the families ask. So that's very important. What I noticed that people don't often ask, but I wish they would. When I do rounds kasi for my chronically ill patients who are referred, a lot of how they live their daily lives are based on misconceptions. The family starts treating the chronically ill patient as an invalid when actually they can still do so many things and still live a full life in spite of having a lupus diagnosis. So not allowed to work, not allowed to continue with school, not allowed to go out, even when they're not in flare, that kind of thing. So it's very important to make the daily life of a lupus patient real for them. It's very important to be specific kung anong bawal, anong hindi. Not everyone asks that. So, yun. So we have to be able to handle the patients and the families' frequently asked questions. Next, what if relatives request that the patient not be told? Because sometimes, well, of course, we prefer to disclose the diagnosis to the patients themselves, but sometimes the families kind of find out or figure it out beforehand, or pinangungunahan na nila. Even before the lab results come out, they already take you aside, they already message, they already call and ask that the patient not be told. Well, generally that's poor medicine if we don't tell, but we still have to be able to work with the family. So what you do is, depending on how close you are with the family, you can actually already say, katawan po nila yun. Karapatan nila ito. For some families, that's enough. For others, especially those with relatively stronger personalities or are more likely to sue you if they don't like how you're handling the patient, how do I say it? Okay. Well, if we don't tell the patient, how can we make plans? How can we decide on a good treatment plan that's going to be effective and that the patient will follow? Because sometimes they might have to do things that they don't understand, and they might not do it and they'll get worse or they'll get a flare, that kind of thing. So we pretty much give it back, turn it back on the family and ask how to handle those if the patient doesn't know. Because we're going to be grounded on, again, having better clinical outcomes if the patient knows. Another thing I also like to say is, what if the patient asks? Because ako mismo, I'm not going to lie to the patient. We have to be able to create a relationship that's built on trust. Some patients, they don't really want to know, is your patient like that? Okay, so it's very important that the family sees what the consequences are if the patient is not told. Also, they kind of tend to say na aatakihin yan or hindi niya kaya. Well, when they do that, I pretty much go back to the last ECG, that kind of thing. if they're stable cardio-wise, then malamang hindi sila atakihin. Kung sasabihin hindi nila kaya, let's see, we also say that that's what we're all here for. Pag hindi niya kaya, sasaluhin natin siya. Okay? Next frequently asked question. When is a psychiatric referral warranted? When the patient requests it, when you're seeing very, very large changes from baseline from the first time you met them to the recent consult where they seem sadder, more anxious, or even if your clinical eye is tagging them that there's something. Go with your gut. It's easier kasi to just send them to a psych and, you know, we might just diagnose that, you know, it's a normal psychological reaction to illness, that kind of thing. I think neuropsych SLE is a bit obvious, diba? Compared to, you know, compared to the subtleties of anxiety or depression. So, yun. Sometimes we can go with our gut or our clinical eye that the patient is different or there's something wrong. Also, diba, most lupus patients are women. Actually, even without lupus, women are really more prone to depression. So that's something for all of us to think about. All right. Next, what if the patient refuses to comply with the treatment strategy? Go back. Maybe there was a misunderstanding somewhere, or the goals are not aligned. So it's very important to check for misunderstanding, realign goals with the patient, and then negotiate. Okay, so since lupus patients are pretty much going to be chronic patients for us, it might be useful to have screening and monitoring tools for mental health conditions. So there's the Hospital Anxiety and Depression Scale, which also comes in Filipino. It was validated in PGH across a lot of our medical and surgical wards. So yun, it was published in ACTA. So you can just find it there. Then there is the GAD-7 or the Generalized Anxiety Disorder 7. It's a 7-item scale that's more focused on anxiety. So it comes in English and Filipino and Hiligaynon, actually. Not necessarily validated for lupus patients, but still useful. There's also the Patient Health Questionnaire, the PHQ-9. It also comes in Filipino and Hiligaynon. Also not validated for lupus patients, but again, it still has potential as a screening tool, as a monitoring tool, but not necessarily for an actual diagnosis of a mental illness. If ever, it will just give us an indication of when a referral is warranted. All right. Then next, there is also the distress thermometer. It's more for just checking, monitoring the patient's well-being. Okay. So remember, before you tell, ask. Always, always meet the patients where they are. The next, remember that the information you give may be important in allowing them to plan for the future. Then always give advice for patients with good prognosis, and always still give advice for patients with poor prognosis. So basically, the road that is built in hope is more pleasant to the traveler than the road built in despair, even though they both lead to the same destination. So thank you very much. I hope I was able to validate the good you already do and give you new things to think about to enhance the patient disclosure experience. Thank you.
Thank you to our speakers, no, Dr. Therese Natividad and Dr. Trina de Llana for very informative and insightful talks, no. They'll be joining us in the open forum right now. So thank you as well to our patients for sharing with us their lupus experience. They give us the reason to understand and improve care in SLE better. So to recap, Dr. Natividad talked about how we diagnose and treat lupus, how we assess their activity, and how their disease activity matters in terms of their outcome. And then Dr. Llana reminded us why we need to learn the important skill of disclosure, no matter how challenging it may be for all of us. I think we will all remember the Spikes protocol and her practical tips. So ano ba yung practical tips? Tissue as motivation. Magkakalimutang magbaon ng tissue kapag nagdi-disclose. No, but seriously, we learned so much from that. Sitting down, asking the patient, really listening to the patient and taking our cue in terms of parceling information and timing from the patient. So Trina and Therese, welcome. We have 480 participants in Zoom and 1,000 here. So we're 1,500 participants strong. And we have a few questions we'd like for you to clarify. First of all, let's talk about the disease. No, Therese? Somebody's asking about causes of lupus, and somebody did share that they have a cousin who was diagnosed with lupus and died after just a month, no, of the condition. Will they necessarily have this disease, and what actually leads to it?
Thank you, Ma'am Hazel. So good afternoon. Good afternoon to everyone. So when we talk about the causes of lupus, the short answer is that the cause is really unknown. So the cause is unknown, but there are really individuals who are born with a tendency to develop lupus, okay? So these are what we labeled earlier as genetically susceptible individuals. What we do know is that there are certain triggers for the disease to manifest, both from within the patient and from the environment. So from the environment, we already know some of the patients who were interviewed were mentioning about it. So sunlight exposure is a very strong trigger. Stress, smoking, okay, these are triggers, and even exposure to viruses. But there is also some hormonal contribution there, and that is estrogen. That's why you'll notice 9-to-1, no? Sa bawat 10 na pasyente, siyam doon babae, females, because of the role of estrogen. And there are also some drugs that may cause what we call drug-induced lupus. Now, a lot of patients, some patients would message me na, Doc, yung kapatid ko or yung pinsan ko nagka-lupus. So for the question of that was in the chat box about a cousin who passed away from lupus and whether there is a risk for that patient to have lupus, what we do know is that there is really a familial tendency. So patients who have relatives with autoimmune disease or SLE in particular really have a higher risk of developing lupus compared to the general population. However, in one of our textbooks in Ruma, it said that to have a second relative, first degree or second degree relative developing lupus within the same family is only 7% of the time. It only happens 7% time. So parang pag-cousin po kasi when we say first degree relative, that's your father, your mother, your child, okay? Pag second degree relative, that's your pamangkin, okay, your tito, your tita, you share only 25% of your genes. Pero pag first cousin po kasi, that's already third degree, medyo malayo na, okay? That is not to say na 0%. But it is also to say that hindi po 100% ang pagkapasa ng lupus. So there is a familial tendency, but it doesn't necessarily mean that you will get it as well.
Yeah. Thank you for that, Therese. No? So it's not absolute, although the risk might be increased. We have another question here, no? Asking about this is I think they're pertaining to subclinical lupus, because the question is, may lupus ba without symptoms of inflammation, and associated with this, can you screen somebody for SLE even if they don't have symptoms? So I guess this is autoantibody testing, Therese?
It really depends on the patient. Okay, when we label somebody as lupus, remember when we went through the clinical criteria, it's really both a clinical diagnosis. Ibig pong sabihin, there should be manifestations already. And that should be hand in hand with your serologic test. It depends on the purpose of the patient. Some patients kasi may have positive tests already, but will it help them? If it causes them more stress, anticipating for something that is not even, has not even happened yet, parang I am more inclined to decline. However, if the patient is really interested and would want to have her serologic profile, then you can go ahead. Of course, when you explain the results to the patient, especially if the results are positive, you have to tell them na hindi po ibig sabihin na nag-positive dito, na may lupus na po kayo. And so, regular monitoring and checking up on the patient regularly will really be the one that will clinch the diagnosis eventually if the patient really has a connective tissue disease.
So sabi nga ni Dr. Trina, no, we take our cue from the patient, but we have to make sure that the understanding is clear. No? Dapat malinaw yung knowledge base kung naiintindihan yung consequences. No? Okay, ito Therese, kasi marami pang questions. Super fast lang. Should they be avoiding vaccines? Can vaccines cause lupus?
Okay, so actually, if you remember the table on the management, one of the advices that we give for all patients, regardless of disease, is really vaccination. Remember, ang lupus po kasi it's an autoimmune disease. The baseline issue is really the immune system. As much as we can support the immune system, we should do so. So vaccinations is not bawal. It's actually encouraged, especially your seasonal influenza and your pneumococcal and your other vaccinations. Very important to keep the patient protected.
Yeah, thank you. Ito, in terms of treatment, 2 questions. Is there such a thing as too much steroids, no? Kaya nga siguro hindi steroids lang, di ba, Dr. Therese?
Too much steroid. That is the reason why, as much as possible, the goal is to, if possible, to take them off the steroids. And that is why a lot of patients are also on additional immunosuppressives. We want our patients to be on steroid-free management as much as we can. And this is where the role of steroid comes in with regard to damage accrual. A lot of the damage or organ damage that we see in chronic patients, long-standing lupus, is really because of steroid effects. However, if the patient is on steroids, definitely your doctor has a reason for it. And the doctor is really managing specific manifestations at the time that would require you to be on glucocorticoids.
That's why it's also important to follow up regularly, because your rheumatologist will actually try their best to make sure that your exposure to any drug, whether it's the second-line drugs or the steroids, will only be what you actually need. No, we have patients who sometimes don't follow up for 2 years, and then you ask them, kamusta na po? Tinuloy ko po yung gamot, and we're the ones who are panicking inside, di ba? Kasi parang hindi siya na-monitor, and we worry about them. Ito, super fast. Is there definite answer to stem cell curing lupus?
I don't think I am in the position to answer this, but we need more studies for this. This is not yet part of any of the clinical guidelines in treatment. So mag-abang po tayo, but wag po nating pangunahan.
So hindi pa po siya standard treatment, but sinasagot po ngayon yan ng mga scientists. Okay, let's talk about the other aspects of care. No, we have some more answers that are specific to SLE here. We'll try to answer them by typing the answers, whether now or later. But let's talk about the other aspect. And I think Dr. Trina gave us very, very practical tips, no, about really disclosing bad news that we can apply to so many other conditions. May nagtatanong na nga ng vasculitis dito oo. Pero Therese and Trina, no, sometimes patients come and nagbasa sila sa internet. How do you handle that? Yung kunwari, let's ask Dr. Trina first. How are you supposed to disclose to somebody na buong barangay nila nag-research na, tas feeling nila alam na nila yung sakit? Tapos when they share the information with you, parang hindi yata masyadong tama.
Okay. So at least you know where they're coming from. when they start sharing all of that with you. So that's important because that's your springboard. I think we've all experienced that it's easier to give new information kesa yung may babaguhin ka sa kung saan sila convinced na. So what I tend to review is, okay ba yung website na pinuntahan nila? Kasi syempre, ang recommendations natin lagi yung yung hospital-based or academically based na sources or yung mga NGOs or WHO, yung mga naman reliable and accountable for what they post or print. That's one. Another one is, kung may questions kayo, maganda rin po yata na tanungin ako. Kasi tayo yung magkakilala at tayo yung magkausap. Kasi yung
nice.
Yung nag-type niyan, yung nag-post niyan, yung nagsulat ng article na yan, hindi kayo kilala. Siyempre, ibabagay natin yung treatment mo dun sa para sa'yo. Kasi marami ka talaga mababasa sa internet at mahaba talaga yung lista ng mga pinag-aaralan ng mga doktor. So, yun. So, I generally draw na tayo yung magkakilala at tayo yung magkausap.
Yeah. So,
they don't know
emphasizing to the patient your partnership with them, no, in this journey. Bago yun, Therese. Gandang tip yun, Therese, no?
Pwedeng gamitin yan.
Oo. So, sige. Bukas line namin yan ni Therese. Kasi tayo po ang magiging magkatuwang, no, sa pagharap sa sakit na ito. This is again for Dr. Trina. Dr. Trina, because the doctors, no, sometimes they make rounds once a day, every other day. And then the patients know that the results are there. And we have so many nurses in the Zoom today. And then they ask, may resulta na po ba? May resulta na po ba? No? How are our other members of the healthcare team supposed to handle that? Patients wanting information and they're not the primary attending who're supposed to do the disclosure. Paano ba yun?
Well, the patients naman are not informed that the results are out as soon as they're out, diba? So, tinatanong lang may resulta na. So, it's an option to answer. Meron na po, babasahin pa po ni doktora.
Paano kung tinatanong nila si nurse, ano pong resulta? Ano po yung nakasulat? Ano pong ibig sabihin? Or they ask information from the other members. Bakit ito yung gamot? No? Paano bang gagawin ng mga nurse members of our team?
Yung mga bakit ito ang gamot, it's easiest to just tag it to the symptom. Don't tag it to a diagnosis yet.
Okay.
Mahirap kasing ang magpautang ng salita. I think that's what all experienced nurses know.
Okay. So that's
something.
Yun.
So number 1 yun. Oo. Tapos number 2, pwede kasing, I think another common problem is if the patient and the family are the ones who bring in the result.
Yes.
Nabasa na nila eh. The cat is well and truly out of the bag and they're already scared. Okay. So if they show it to the nurse and then they start asking about it, actually kahit sino nurse, well, dapat kaya yan ng fellow.
Secretariat. Our secretaries in the clinic, diba?
Secretariat.
Or we have medtechs here. Sometimes pagka abot sa kanila ng medtech, tinatanong yung medtech, ano po yung resulta? Paano ba yun?
Oo. Well, pag sa, if it's a nurse na nagra-rounds siya with the patient, tapos papakita sa kanya yung paper, tapos ano po ibig sabihin nito, ano diagnosis ko, what you can say is, ay, napakita niyo na po ba yan kay doktora? Pwedeng ganun eh. That's one. Or, so babasahin nyo, let's say, confirm nga na anti-ANE positive. Babalik yung nurses natin eh. Babasahin pa po yan ni doktora, hindi naman porket ganyan yung itsura ng laboratory, final answer na. And then you repeat na, mahirap po kasi kung mag-a-assume ako, kayo po yung mas nakaka-discuss ni na doktora kahit bago pa kayo na-confine.
Okay. So putting it back in the perspective of really looking at the patient as a whole, no? And their relationship with their primary caregiver. I think that's really very nice to hear, no? So if you're a tech and you're being asked, you can say na, can be hospital policy, we don't interpret results, or these results actually have to be interpreted in the light of everything else that's happening to you, which is what Dr. Therese was emphasizing in terms of screening and diagnosis. Okay.
Or pwede ring, it's not my specialty. Baka may mali akong masabi.
Yes. So, making sure, no, na tama yung information na mabibigay. Okay. It's 12:15, but we have so many more questions here. Maybe this is one thing, no, that we'd like to discuss. Sometimes you have patients you've discussed, you've disclosed as best as you could, but they don't adhere to your suggested plan of treatment, or sometimes the negotiated plan of treatment. How do you do it? Therese, maybe from experience, and then maybe we can get input from Trina, how we can better improve how we do these things.
Ako, ma'am, very important sa akin that you have a partner in the management. If the patient is an unwilling partner, get somebody else within the family. So usually, if the patient is married, I ask really the husband or the sister, or if it's a young person, the parent, the very trusted family member to be with the meeting at all times, so that it's always three of us. So even if the patient is non-compliant or poorly compliant, there you have a family, member who will be your advocate at home, kasi you only see the patient every so often. So you have to have an advocate at home who understands the management, who understands the goals and the importance of each of the medications that we are given. Because if we have those people with us, kahit pa paano, matutulungan talaga tayo sa management. There are those also who are suddenly lost to follow up. So kailangan naiintindihan ng magulang o ng asawa na how important it is for the patient to follow up, because the treatment is not static. Gagalaw at gagalaw, magbabago, and there are things that you want to achieve. So ako yun, ma'am. There are really patients who are difficult patients in terms of compliance. Siguro ako, I really ask always a family member, a trusted family member of the patient to be with us when we discuss management.
So very important to work together, no? Really with not just the patient, but that's why ang first rule ni Dr. Trina about setting is actually inviting the maybe significant others to join you, or even asking the patients, whom do you want to be in this meeting? Kasi hindi pwede kung minsan na dalawa lang tayo, no? So, and we do encourage our patients to read about their conditions, to get information about their condition. But actually, what we want is for our patients to get reliable information, no? Kasi nakakalungkot talaga, because sometimes our patients in their vulnerability are become, how do you say it? Become, I don't want to say it, but they fall prey to people who may have less than noble intentions in terms of supporting them in their journey. No? So we have a lot of questions on this in the chat about supplements, about other treatment strategies for SLE, but we will be answering them in the chat box because we have limited time really for this webinar. There's no deadline for the questions except that we only have up to a specific amount of time to convey this with you. Just to wrap up, what has been a very interesting series of questions and discussion. So we know SLE to be a chronic condition, and like most chronic conditions, it requires really good partnership between the healthcare team, the patient, and the patient's significant others, for us to be able to address all of the issues of the patient, whether it's flare, so that we could improve their outcomes. We need to be able to craft a good plan of management moving forward. And this is only possible really if we have full information available to the patient and their family members. And for us, members of the healthcare team, we have roles to play in all of these in terms of disclosure, in the day-to-day questions that we need to answer for the patient's care. No? So we learned to do that this afternoon, and I hope in this brief hour, we were able to share with you practical tips on how to answer questions for our patients with SLE and also give you an update on SLE itself. So thank you, Dr. Therese and Dr. Trina, for sharing the morning with us. And thank you for our, ilan na ba? 1,500 participants who are here with us today. You have made our division head very happy on her birthday. This also, we would like also to thank the Information Management Service Network team of UP Manila for hosting us in this webinar, and our sponsors, AstraZeneca, for their continuing support. We thank you all for joining us as we end the first LMLR for this year. There's going to be 3 more, and we hope to see you all on June 15 on an equally important topic, which is gout. So again, our heartfelt thanks, Dr. Therese Natividad and Dr. Trina de Llana. A heartfelt thanks as well to our participants, and we hope that all of you will have a great afternoon ahead.